Hello and welcome. I'm Vivian Sisskin, and I'm a clinical professor in the Department of Hearing and Speech Sciences at the University of Maryland. I'm also the owner of the Sisskin Stuttering Center in McLean, Virginia. I'm here today with my colleague, Samantha Wassilis, and we are going to be talking about a kind of disfluent speech that may not be stuttering or cluttering. We will be addressing atypical disfluency, specifically word final disfluency, also known as N-word or word final repetition. We will cover what is known to date about this form of disfluency, review profiles of children who demonstrate it, and present a behavioral approach to treatment that we have found to be effective with good long-term outcomes for, as of now, about 20 cases. We want to be transparent from the very beginning that there is very little published data to inform our understanding of word final disfluency, but we have many accounts through case descriptions. Our hope is that you will gain a greater understanding of the possibility that word final disfluency may be distinct from developmental stuttering, diagnosed as child onset fluency disorder. We'd like to begin by establishing some common vocabulary. Since you have likely already learned about stuttering, we're going to review types of disfluencies and place them in 3 categories. These categories help us in diagnosis and in differential diagnosis when evaluating clients with fluency differences. Let's begin with stuttering-like disfluency, those often associated with the diagnosis of stuttering in young children. They include part word repetition, for example, Vivian. Whole word repetitions are most often single syllable words characterized by tension and timing when they're in this category. I live in Vienna, Virginia. Prolongations can occur on consonants, Vivian, or on vowels, Vivian. Silent blocks usually involve cutting off phonation and sometimes respiration. Vivian. I made a little noise there to signal that there's some struggle, since you may not be watching my face and watching the slides instead. Now let's move on to the next column. Other disfluencies are sometimes called between word disfluencies or normal disfluencies because they are found in the speech of typical speakers when formulating or word searching. In young children near onset, we see that the presence of other disfluencies can reflect how language complexity or expressive language learning might impact fluency. For example, word repetition and revision. Later, as the child who stutters begins to react to disfluency, these other disfluencies might represent escape or coping mechanisms, that is, linguistic strategies to avoid stuttering. I'll give you an example of phrase repetitions. My name is Vivian. Those phrase repetitions were in an effort to escape from the disfluency that was inevitable in my mind on Vivian. The last column, atypical disfluency, is the most unusual here. And while sometimes accompanied by both stutter-like disfluencies and other disfluencies, it is often the only form of disfluency present in our clients. Word final repetition is sometimes called rhyme repetition. For example, I went on a ride-eyed. Final consonant repetition has been reported as final repetition of stop consonants, hit, t. Midword insertions or breaks may sometimes have an H insertion within the vowel. For example, he go ho to the park, hark. Final sound prolongation are most often on continuance, for example, wishes, and in my experience can sometimes be confused with atypical force and duration. These are prosody issues in some speech patterns of those with autism. I think you won the game. Again, not atypical, but more prosody issues. Final phrase repetition may resemble palilalia. However, we don't necessarily observe the increase in rate and decrease in intensity as the utterance continues. as we might often do in neurogenic speech disorders, for example. Today, we'll be talking about this last column of behaviors. We will review what we know about them and also what we don't know. We will demonstrate an example of a treatment approach that we have found very helpful with excellent outcomes. Finally, we will be doing some conjecturing about their cause, function, or underlying processes. Over the past 40 years or so, word final disfluency has been documented among typically developing children, children with developmental disorders, as well as among children, those with neurological impairments, mostly through case studies. Let's review some of those early cases in typically developing children. Rudman and colleagues identified word final disfluency in young children with language learning issues and offered phonological explanations. McAllister and Kingston identified word final disfluency in 2 typically developing school-age boys. Atypical disfluency has been documented among those with genetic syndromes, developmental disorders, neurological impairments, and through case studies, Van Borsel and colleagues identified word final disfluency in Prader-Willi syndrome, Tourette's syndrome, neurofibromatosis, Down syndrome, and brain injury. Stansfield identified these disfluencies among 4 adults with learning disabilities, and more recently, Evans and Owens described an adult case with ADHD. We have highlighted autism spectrum disorders in red, as this is the largest group outside of neurotypical children that we're hearing about. We are seeing reports of cases among those with autism more frequently in the literature and also anecdotally. Do we know the numbers, the incidence, prevalence of any of these cases? No, there's no research yet. And the reason I wanted to point out these studies to you is because with a search of the literature, there aren't that many. So let's take a moment to note that disfluency among those with autism may be elevated in general. Plexico and colleagues found 7 out of 8 children with autism to have disfluencies in each of the 3 categories that we described earlier. Scaler Scott and colleagues found 36% out of 11 children they studied to present with disfluencies of varying types. While some children with autism will be diagnosed with stuttering or cluttering, others will present with disfluencies in the other category, other disfluencies that we described earlier. Some of these might be non-meaningful pauses, phrase repetition, and reformulation. Just as a reminder, we will not be talking about therapy for those disfluencies today. So let's talk a little bit about the multidimensional profile. The multidimensional profile of most of our clients is fairly similar. Awareness of the repetitions is variable. Some are aware and others not. While some children are aware, they most often do not present with secondary or concomitant behaviors, often seen in stuttering. Emotional reactivity is absent, and attitudes about communication are positive. They don't hold back from speaking, generally have good self-esteem, and enjoy communicating. They do not see the disfluencies as a problem, though their parents are concerned. Parental concern is often related to worry about future teasing or impact on social interaction or academic development somewhere down the line. The decision to treat, often based on the notion that taking care of this now will prevent problems later, is generally what we find in our cases. So let's take a little bit of a deeper dive here. What are the various patterns of word final disfluency? A study by Teitler and colleagues reported a phonological analysis of the word final disfluencies of 8 neurotypical French-speaking children. I will just summarize their findings, by saying that the French-speaking children, like American children, mostly presented with repetition of the nucleus and coda of the final syllable, forming a rhyme repetition. In this case, number 1, garçon ont or venu eu. This is the first published linguistic analysis of word final disfluency. I imagine there'll be more to come. We're also learning something about the kinds of linguistic contexts that increase the likelihood of word final repetition. A study by Healy and colleagues in 2015 looked at the conversational speech of a 12-year-old boy with autism and word final disfluency. Both linguistic complexity and length of utterance increased these disfluencies, as did the child's interest level in and initiation of conversation. So this is a good time to talk about what we don't know. What we do know and what we don't know about a child in disfluency are presenting, what we do know and what we don't know about what the child is presenting are considerations in therapy decision-making. Is this a fluency disorder or a fluency difference? We don't know. How common is it? We don't know. Is there evidence of unassisted resolution? For example, spontaneous recovery, as you probably learned about with stuttering. We don't know. We don't know if it'll resolve on its own. How effective is treatment? Is treatment evidence-based? We don't know. We do know that we see a lot in children and we don't see a whole lot in adults, but we do see it in adults. We need some research to determine how these resolve and if they do. Sam and I have kept careful records of our treatment cases, ensured that therapy was responsible for change, searched for replacement behaviors after therapy, and examined long-term spontaneous outcomes. Despite our practice-based evidence, therapy is not for everyone. We have important discussions with parents about the pros and cons, considering both client desires and parent concerns. Balancing those out are important. The most important discussion point is that we will be bringing the child's attention to a behavior that they were previously unaware of. And even though the therapy is fun, we need to discuss notions of changing or fixing one's speech during a time when Sam and I are resonating more with the social model of disability and considerations related to neurodiversity. For some children with little to no awareness, who sees the problem? The adults, parents, teachers, speech-language pathologists. The children and teens often don't care. Put very simply by one of our 15-year-olds, frankly, I don't see a problem. Many children will tell me directly, I like the way I talk. In some cases, for example, children with autism, we might consider that therapy to improve functional communication and social interaction might be a higher priority than word final disfluency, even though less visible to the parent. As we move into therapy, we need to consider the evidence. What framework is valid? What strategies are useful? What outcomes can we expect? When it comes to evidence, the discussion is short because the data is minimal. Published case studies, while limited to these two at the moment, demonstrate successful treatment for word final disfluency with very different cases. One by Van Borsel and colleagues in 2005 with a 12-year-old Dutch boy with brain injury. It is unclear if he presented with word final disfluency prior to injury. The other case by me and Sam in 2014, reporting successful treatment for an 8-year-old with autism. Both studies used behavioral treatments that included identification of the disfluency and a variety of activities to suppress it. Other cases have been noted, but as of yet, there has not been any solid outcome study. At this point, I'm going to pass the discussion over to Sam, and she will describe our behavioral treatment and offer some tips for positive long-term outcomes.
Thank you, Vivian. I'm here today to share with you a framework for treating atypical disfluencies using a behavioral treatment approach. As Vivian mentioned, practice-based evidence of nearly 20 cases has informed this treatment, consisting of 3 components. The first component, the onboarding process, initially includes assessing the client's awareness and readiness to change. Information gathered during intake or consultation will inform how the clinician approaches each individual client in terms of where to begin therapy. For those clients who demonstrate awareness, our clinical experience has found it helpful to have the client name the behavior, with many of them coming up with quite creative names, including echoes, extras, and over agains, and even a name entirely unrelated, such as potatoes. This ownership helps to create a client-driven approach to treatment and helps to empower the client. We've also found it helpful for several clients to increase interest and motivation in changing the behavior through an open discussion on our lack of understanding of these behaviors and asking for their assistance in helping to help us figure this out. After the onboarding process, the second treatment component includes teaching monitoring in a highly structured manner to increase awareness of atypical disfluencies, leading to a reduction through negative practice. Where to begin teaching the skill of self-monitoring will vary based on client factors. For those clients who demonstrate awareness, it may be appropriate to begin monitoring the behavior almost immediately. For clients who do not demonstrate any awareness, or for younger clients, we recommend beginning by teaching monitoring using non-speech behaviors such as a tap or cough, and beginning with monitoring in the speech of the clinician or family member. Once the client is able to successfully monitor different behaviors, including the target behavior and others, it is appropriate to work towards self-monitoring with fading support. During this process, we have noticed both visible, and audible inhibition and suppression of final repetitions, which can be reinforced at this time. Ongoing assessment for a replacement behavior and client self-evaluation is also important during this stage. The final stage in treatment, which is embedded throughout the process of monitoring, includes program generalization and carryover. Strong parental or caregiver involvement during sessions and daily home practice are vital to reducing this habitual behavior. It is important to support parents and caregivers with incorporating daily practice into their schedules and assisting them with developing linguistically appropriate and creative ways to engage the client at home. We also have parents model what they'll be working on at home each week during our sessions and plan for time to problem solve home practice. Counseling related to feedback and reinforcement may also be needed. Although we provided a treatment structure, each case requires a highly individualized approach. As with all good therapy, it is important to establish a strong therapeutic alliance, especially with those clients who are less interested in reducing these disfluencies. Topics and activities of interest to the client should be used to address client motivation and willingness to participate in sessions, especially since these cases are often through parent referrals and there's little to no life or emotional impact on the client. As Vivian mentioned, it is important to consider the learning style of each individual client when programming treatment and implement creative problem solving, especially for those on the autism spectrum. Concrete strategies have been helpful for many of our clients, including visual supports, such as drawing a visual representation of speech as the client is speaking. For example, a straight line to represent fluent speech and a loop to represent the disfluency. Be sure to include self-evaluation and self-management to build in generalization.
At this point, you might have some good ideas about how to begin with these clients, but you should also be asking some questions. If it is not stuttering, what is it? As there may be many roads toward final disfluency, let's consider some. First, working memory strategies may be at work. In a study by Lake and colleagues in 2011, fillers such as and were observed less often in adults with autism than their typically developing peers. They hypothesized that those with autism used repetition instead of fillers to hold the floor. Fillers, are a convention for letting the listener know you are thinking. They are listener-oriented placeholders. Repetitions, on the other hand, are speaker-oriented placeholders. They hold the floor by repeating one's own speech. Could word final repetition be a surface indication of working memory differences? Possible. Next, consider perseveration as a possible explanation. Could these clients present with lack of flexibility of thought or difficulty shifting gears? This is noted in the verbal behavior of scripting and also in terms of difficulty with change and transitions. It is possible that word final disfluency may reflect difficulty in termination of words. Or perhaps word final disfluency is a verbal form of motor stereotypy or restricted repetitive behavior often seen in autism. Word final disfluency could be linked to anxiety or obsessive behavior in this case. And another idea, the behavior is serving a function of self-regulation with a means of persistence. This may be plausible for individuals with poor self-monitoring skills or poor self-regulation. Perhaps word final disfluency actually aids in self-regulation. There is some support for this notion. In 2009, Singer and Bashir reported using self-regulation strategies to improve oral language in language-impaired children. Finally, we may speculate that a function for word final disfluency is an attempt to repair communication, either to seek consistency or to manage increased cognitive demands. In 2007, Sterling and colleagues reported an increased disfluency during story retelling by children with autism, reflecting efforts to repair or to manage increased cognitive demands. Theories are mounting. No doubt, research is needed to understand what word final repetition is all about. So, as we draw to a close, what are some of the take-home messages? Word final disfluency observed across populations, often reported in neurotypical children and children with autism. It is not limited to autism. There are individual differences among the profiles of those who demonstrate word final disfluency in terms of awareness. However, we have not observed much reactivity in the form of struggle, avoidance, or emotions and attitudes. Treatment considerations should include priorities for functional communication, child desires, and parental concerns. For those with autism, teaching strategies and session design must draw from the learning style best suited for those individuals. While we can only speculate about the function of explanation for word final disfluencies, case studies demonstrate that short-term behavioral treatments, like the one we described here, can be effective in significantly reducing it with lasting change. We leave you with our hope that you will feel confident in addressing word final disfluency among your clients.